What treatment should I have for maintenance therapy?
Maintenance therapy. Right now, the approved maintenance therapy by the FDA and also the European Medicines Agency is lenalidomide. The current dose is 10 milligrams daily with an adjustment up to 15 milligrams daily, or a de-escalation down to 5 milligrams daily or 5 milligrams 3 weeks on, 1 week off. That is how the original studies were done. And that right now is the standard, at least what is officially approved. Some of the other studies all looked at 3 weeks on, 1 week off, and most of the time it was 10 milligrams. And so that's another option. It's not officially the label, but it does allow patients to get a little break and to have a little bit higher dose as opposed to 5 milligrams 3 weeks on, 1 week off. So I think either 10 milligrams 3 weeks on, 1 week off, or 10 milligrams daily are reasonable. But the most important thing is the patient has to tolerate it. If the patient is just miserable, that's just not fair to torture the patient that way. So you have to come up with strategies depending on what the toxicity is. Most of the time with lenalidomide, toxicity can occasionally be GI, and so things like cholesterol or other bile salt binding agents can sometimes mitigate or decrease that toxicity. Rarely you can get some rashes, sometimes with pulsing of steroids, and then trying to adjust the dose may allow the patient to tolerate it, because you don't want to have the patient itching like crazy because of the drug they're receiving. So those are sort of general principles regarding lenalidomide, maintaining it. There is a second cancer risk with patients who receive lenalidomide. We don't understand that enough. It seems to be the combination with the high-dose melphalan predisposes to this. And it's about a 2 to 3-fold increase in these cancer risks. But patients who receive lenalidomide maintenance have a lower risk of having their disease come back and a lower risk of dying of their myeloma compared to those who didn't receive maintenance. So it's sort of a pick your poison, but it's better to be alive and at risk to get that second cancer than to be deceased because the myeloma came back and you died from it. But we want to make sure that we understand this better. We don't know yet why this occurs. And again, there are lots of people trying to figure this out. That's the major long-term toxicity, which we always need to be thinking about. But we still think it's, as long as the patient understands those risks, that it's still reasonable to take this, because it does keep the myeloma away, which is a far more pressing problem than the risk of a second cancer. There are other drugs that have been utilized. The Europeans studied bortezomib for 2 years, but it was compared to thalidomide for 2 years. And thalidomide's a tough drug to handle as maintenance because it's pretty neurotoxic. It also causes fatigue, but it can be utilized. I think lenalidomide's a more effective drug and a little bit better tolerated. Problem with lenalidomide is not quite as effective against high-risk cytogenetics, but neither is bortezomib. When you look at the data, the patients who got that bortezomib for 2 years, it worked better in deletion 17, chromosome abnormality, myeloma, compared to thalidomide. But if you look at those numbers, you're not supposed to clearly do cross-trial comparisons. The progression-free survival is about the same with lenalidomide as it is with bortezomib. Why? Because bortezomib is being compared to thalidomide. And that's why it's an inferior drug relative to, say, lenalidomide. So we're up in the air on this. The Emory group had a trial looking at lenalidomide, bortezomib, dex in lower dose, so-called RVD light. Did that for 3 years, then followed it by len maintenance until progression. And they had a comparable progression-free survival when you compare it to the other trials, but they didn't have a comparator arm. It was just a single high-risk patient population. So for high-risk disease, high-risk cytogenetics, very high-burden disease, high LDH, according to the revised ISS scoring, we need to find better strategies for those high-risk patients, which are about 20% of myeloma patients. For the lower-risk patients, we go still with single-dose lenalidomide.
Currently available maintenance therapy options include lenalidomide or Revlimid, and this is the one that's been, I think, the most studied, with the most number of randomized trials supporting its use. And it's probably the most commonly used maintenance in the United States. An alternative option would be bortezomib or Velcade, and there have been some studies that have looked at bortezomib maintenance and also shown a benefit. It's typically given on a once every 2-week basis as a subcutaneous injection. It hasn't been quite as well studied as lenalidomide. It can be an option for patients who can't tolerate lenalidomide, either due to bad side effects or if there are copay issues. The other maintenance option that's been reported in a randomized trial recently has been ixazomib, also called Ninlaro. And this is an oral pill that is very similar to bortezomib or Velcade. It's given weekly for 3 weeks on, 1 week off. And in a recent randomized trial, ixazomib or Ninlaro maintenance also extended the progression-free survival, meaning the time patients stayed in remission, compared to a placebo. But the magnitude of benefit didn't seem as high as some of the Revlimid-based trials. And so for me, I think this is more of a second choice compared to the lenalidomide maintenance options. So those are the ones that are most commonly used right now. There are a number of studies, however, going on that are looking at alternative maintenance options, including daratumumab, a monoclonal antibody, elotuzumab, another antibody, as well as combinations of more than one drug together. And so we hope over the next year or two, we'll start to get some of that data that will tell us some of these alternative options, or even using 2 drugs may be better than using one of the current drugs. With high-risk patients, sometimes we will think about a proteasome inhibitor maintenance or even a dual maintenance option where we'll use a proteasome inhibitor and an immunomodulatory drug like Revlimid together. And that hasn't been studied in randomized trials, but there have been some published studies from single centers suggesting that those patients may have more durable remissions than you might otherwise expect. So there also is some data, again, more retrospective, that patients with the 414 translocation, which is one of the chromosome changes that can confer high risk, may benefit from a proteasome inhibitor maintenance. So that's one of the ways the risk stratification may influence our choice of therapy.
So the most commonly used maintenance strategy is lenalidomide or Revlimid, typically given as a single agent. Multiple phase 3 studies have been performed comparing lenalidomide to placebo or lenalidomide to no maintenance therapy. And whether it's after stem cell transplant or whether it's done in a non-transplant setting, over and over and over again, the use of lenalidomide maintenance therapy significantly prolongs remission. And that's been shown across multiple phase 3 studies. And in the transplant setting in particular, there is what appears to be an overall survival advantage that has emerged with the use of lenalidomide maintenance therapy. So it is considered the standard of care for maintenance therapy in myeloma patients. There are other options available as well. So recently, for example, ixazomib or Ninlaro, which is an oral proteasome inhibitor, which is structurally related to bortezomib or Velcade, that was also tested after transplant, comparing Ninlaro to placebo. And what they showed was an improvement in progression-free survival with the use of that particular agent and it was very well tolerated. Now the response, the difference in progression-free survival was not as dramatic as it was with the lenalidomide studies as well. So I think Ninlaro or ixazomib by itself would be a good option for somebody who has previously been on Revlimid, lenalidomide, and has not tolerated it well.
How does the dosage of maintenance therapy differ from the dosage of induction therapy?
On average, the maintenance therapy doses are far decreased from where they are at newly diagnosed. The idea is that maintenance therapy is not really like an oil and filter change. Maintenance therapy is continuous suppressive therapy until they either can't handle it anymore or the myeloma becomes resistant to it. We need to have a good quality of life to continue it. So maintenance therapy doses need to be decreased for patients to tolerate it long term. The components of maintenance therapy are difficult, and in patients with resistant myeloma or high risk or stage 3 on the revised ISS, those patients are often treated with 3-drug maintenance suppressive therapy, whereas those patients who have stage 1 on the revised ISS, they'll often just get Revlimid maintenance. And so we often treat based on the type of myeloma they have, and the more resistant myeloma will often be given suppressive 3-drug therapy, where the easier to treat myeloma gets suppressive single-drug therapy.
Of note, we need to do a better job with risk stratification, because even though somebody may be a revised ISS1, there's still some of those patients who progress early. Same thing with revised ISS2. And there's some revised ISS3 patients, higher burden disease, higher risk, who do well. So we need to come up with better strategies to truly risk stratify our patients so we can say with 100% certainty, your disease is going to come back sooner, we have to do something more aggressive, or your disease is going to behave in a very benign way, and we can develop a strategy that's a little less intense for you because your disease is going to be controlled for a very long period of time. That's the big goal that we need to do, is to understand the biology of myeloma for all of our patients.